Assalamu alaikum, everyone. Good morning. And welcome back to the new year. I know you guys are almost done with your first block, hence I'm giving this session to you guys. And it's on endocrinology reproduction, specifically on the OSPE portion. So I really hope it's helpful. I hope it's beneficial for you guys. And again, if you guys have any questions, I know this is a recorded session, but at the end, please feel free to contact me or reach out. And if you guys find anything that might be possibly incorrect that I put in here. Okay, so now let's just jump right into it. So basically, the things that you guys really need to focus on when it comes to your OSPE is relating structure to function. So understanding like the anatomy and the histology specifically, because that's their opportunity to ask you guys about the things that you learned in lab. And the majority of those things are anatomy, histology, and then relating the structure to the function. And sometimes when you're looking at these things, they're going to ask you about embryological origins as well, and then relate the physiology of it. So majority of your physiology, of course, is like, in your lectures that you've taken and maybe in the other pals that you have gotten. But over here, there's not as much physiology as much as there is relating that physiology to the structure that you guys were studying, okay? So I know there's endocrinology and reproduction, so a lot of glands and a lot of organs. I try to include the most common types of questions asked in here. It does not cover every single detail that you could possibly be asked about in your OSCE. Sorry, OSPE, so used to saying OSCE. I tried to cover a majority based on what people have gotten in the past in your batch exams and looking at the content that you guys generally have. The only thing that I unfortunately was not able to include in here due to time is the anatomage files, but definitely go over those and look at the labeled versions and everything because understanding where the structures are is incredibly important, and I am pretty sure they're going to bring it in your OSPE. So let's start with endocrine. Now, in your OSPE, of course, it's not going to be divided into endocrine and reproduction or endocrinology and reproduction. It's all going to be just mixed questions. But for the sake of, this is just a review session. I don't want you guys to look at a structure and then be confused as to like, wait, when did we learn this or whatever? I just kind of divided it into the two. All right. So let's go with the first question. Also feel free to pause and then try to answer these on your own and then continue playing, okay? So what is the following structure that the arrow is pointing at? So what is this right here? So as we know, and you've probably seen this radiograph specifically a bunch of times, this is the pituitary gland, okay? I don't know why I put anterior here. It is just the pituitary gland. So I will correct that before I send it to you guys. So what is the embryological origin of the structure? Feel free to pause. Okay, so the embryological origin of the structure is Rathke's pouch. So the surface ectoderm. Specifically, now I remember why I put anterior. This is the origin of the anterior pituitary gland. So remember that you have the anterior and posterior, and we're going to look at this again in a little bit. But the anterior gland, anterior pituitary gland, yes, is originated from Rathke's pouch, which is from the surface ectoderm. Also, sometimes like the Rathke's pouch is known as the oral ectoderm. Whereas the posterior pituitary gland comes from another part of the ectoderm, which we'll talk about. So over here, you can see I took this straight from the first aid for the US Assembly Step 1, 2023. Ectoderm, so the surface ectoderm will give you your adenohypophysis from the Rathke's pouch. Adenohypophysis is another way of saying the anterior pituitary gland. And you have the neurohypophysis, which is the posterior pituitary gland, which is given by your neural crest cells. Sorry, your neural tube. I'm so sorry. So neurohypophysis is your posterior pituitary gland, okay? So they're both from the ectoderm, but it's important to know that the anterior and the posterior are from different parts of the ectoderm. So the anterior, again, is from the surface ectoderm, and the posterior pituitary is from the neural tube, okay? The mesoderm will give you other things. I just want to put this here so you guys could see. But I put this here as well to show you that there are certain structures that will come from the mesoderm. Now, next question. Feel free to pause. So the patient's vision, this is the patient's vision, and where is the tumor most likely located, or where is the mass most likely located? I didn't jump into writing a whole vignette for this question because I'm sure you guys have seen this multiple times, so this is for the sake of reviewing the concept. So feel free to pause and answer on your own first. Okay, so This is the patient's vision. So where is the mass most likely located? So we know that this patient is only able to see in their nasal field and not in their temporal field. Hence, it's basically whitened off over here. They're not able to see in their temporal field of vision. Temporal meaning this is temporal, okay? So if they're not able to see on both sides temporally, that's called bitemporal hemianopsia, okay? So bitemporal hemianopsia, and you guys have heard about this and you've heard this term multiple times by now, is usually caused when there is a compression on the optic chiasm, okay? And usually masses that are originating from the pituitary gland in the sella turcica, where the pituitary gland is located, compress on the optic chiasm, and that will give you this field of vision. So if you see this, then, or if patient complains that they're unable to see over here, they're only able to see like, nasally or something, they'll have a different way of describing it. This is what you want to think about. And then therefore you're going to be imaging for these things and then doing your investigations based on these things. That's for the future though. All right. So here is an example of the regular radiograph that we saw before. This is an MRI image. And then over here, you can see that there is a huge mass in place of the pituitary where it normally looks this size. It is now taking up this much space. So of course, that's going to compress on the optic chiasm, specifically the fibers that will go to communicate your temporal field of vision. All right, next question. A patient presents with polyuria and always feels very thirsty. Despite drinking a lot of water, the patient still feels thirsty and continues to urinate a lot. Which part of the following structure is affected? So feel free to pause and try to answer this on your own. Okay, so over here, this image, without me telling you, without anyone telling you, you hopefully should be able to figure out that this is a histology slide of the pituitary gland. And there are certain features that will tell you that. So over here, I've labeled it A and B. And as you guys will know, A is the anterior and B is the posterior. Now, how do we know this? How do I know that A is the anterior, B is the posterior? Well, histologically, remember, A for anterior pituitary, it's the adenohypophysis, and therefore adenohypophysis from its name, it's basically more glandular, so it's making hormones that will act on other organs and glands in the body. Whereas B is a neurohypophysis, and you know that in neuro or like neurons, when you stain them, they're going to stain differently. So over here, there's more substance, but over here there might be more of a substance that does not allow staining. And usually that is the case for when you're looking at brain tissue or any neurological tissue. So that's how you can tell that this is posterior and this is anterior. Also in the anterior, you're going to remember that there's basophils, acidophils, etc. So basophils and acidophils stain heavily, and that's what you see over here. This is staining heavily, whereas this is not. So therefore anterior, posterior, okay? So therefore, the answer for this would be B. And the reason is this patient has what is known as diabetes insipidus. And diabetes insipidus, there's two types, central and nephrogenic. You guys don't need to know about nephrogenic right now, so don't worry about that. But central diabetes insipidus is when there's a lack of ADH production. And ADH, as you guys know, is released by the neurohypophysis, which is the posterior pituitary gland over here, okay? That's why it's B. So as we mentioned, A is anterior, adenohypophysis, B is posterior, neurohypophysis. Now let's dig in a little deeper into that. So which of the following labeled cells responds to hypothalamic gonadotropin releasing hormone? So you guys can take a minute to try and figure that out or answer on your own. All right. So the answer is A, basophils, okay? So you have your basophils, A. You have these cells, which are a lot more pink or red, known as your acidophils, which are labeled B. And in C over here, you see something that is not really picking up color. We can say it's scared of color, AKA it is a chromophobe. So these are literally called your chromophobe cells. So this is actually in your anterior pituitary. As you guys know, you guys have three main types of cells. So you have your acidophils, your basophils, and your chromophobe cells. Okay, and they're all responsible for different things. So we'll talk specifically about the acidophils and basophils. So A are the basophils, B acidophils, C chromophobe cells. And the basophils are responsible for the excretion of growth hormone and, if I'm not mistaken, prolactin. And your basophils, sorry, and your acidophils are responsible for the other things, your FSH, LH, TSH, etc. Okay? So now, if we change this question with the same image too, a patient presents with headaches and visual changes. He is tall, has long limbs, coarse facial features, frontal bossing, and a protruding mandible. Which labeled cells are going to be increased in number in this patient? So I'll give you guys a minute to try. All right, so let's think about it this way. We need to understand his presentation physically. So, of course, facial features, long limbs, frontal bossing, protruding mandible. So these are all pointing towards a specific thing called gigantism. And usually this is due to increased growth hormone production. And as we know, growth hormone is released by B, acidophils. Okay, so these very pink red cells. So these would be increased in number. Let's just say if you were to take a sample from this patient of the pituitary after you take after the neurosurgeon resects the pituitary adenoma, because it's usually an adenoma that causes a high increase in the growth hormone because there's an increase in acidophils. Okay, that's what you're going to see in your microscope when you take a sample. You're going to see a lot of acidophils. So they're responsible for secreting growth hormone and prolactin, and gigantism is due to increased growth hormone production from the pituitary, usually due to a pituitary adenoma. And that can be what is causing or contributing to the headache and visual changes. Usually headaches and visual changes can also be because of the growth hormone. There's increased bony production in these patients basically in their body. So that's where you're going to have, of course, facial features, etc. But some of those bones can kind of compress on certain nerves and therefore can cause visual changes as well. So the visual changes don't necessarily only have to be bitemporal hemianopia. There can also be other visual changes as well in patients like this. But typically bitemporal hemianopia is the most common one because of the pituitary adenoma itself. But in patients specifically with gigantism, because of the nature of that, like, I don't know if disease is the right word, but because of the nature of gigantism as what it is, which is increased like bony production and growth hormone related growth in the body, your bones will also increase in size, and then that can happen over here, and they can compress on your optic nerve, on your other nerves that control eye movement, etc. So over here, gigantism, this is a very, very quick summary that is from Ambos. Abnormal linear growth during childhood due to excess growth hormone, while the epiphyseal growth plates are still open. So that means that they're going to grow very tall. And again, their bones are going to grow very quickly as well and a lot larger, and then go into spaces where bone is not normally supposed to grow into, in terms of like if you have a canal, it might become narrow like this because of the increased bone growth. Next question. Okay. So as you guys can see, when you look at these things, you should be able to tell which structure you're looking at without it being labeled or titled, okay? Like obviously in the histology lab, it's going to be titled when you guys are taking it and looking at it under a microscope, but when you look at this, you should be able to, with the question, with the context of the question, be able to figure out what you're looking at. So, which of the following labeled areas is responsible for secreting the hormone implicated in Cushing's disease? So pause and try to answer first. All right, so first let's look at the answer and then discuss. So the answer is B, this area. So what we're looking at is the adrenal gland. So we're not looking at it as a whole, but we've zoomed in. So over here, what you can see is the cortex of the adrenal gland, as well as the medulla of the adrenal gland. I hope you guys can see my cursor moving. So cortex, medulla, okay? Now the cortex is divided into three portions, and I like to think of it as GFR. So the zona glomerulosa, which is the most outer part, and in the middle is the zona fasciculata, and then inside is the zona reticularis, and they're all responsible for different types of hormone production. So over here, the reason it is B is because the zona fasciculata is responsible specifically for glucocorticoid production, and one of those is cortisol or cortisone. And cortisone is the hormone that is implicated in Cushing's disease. Now, if I said that this person had Conn syndrome or Addison's disease or something like that, and I said which of the following labeled areas is responsible for secreting the hormone implicated in that, then what would your guys' answer be? Feel free to pause. So your answer in that case would be A, because the zona glomerulosa is responsible for mineralocorticoid production. And a way that you can remember this, or a way I like to remember this, is like glomerulus is like the thing that's in the kidney, right? The structure in the kidney. So the glomerulus is in the kidney, and what acts on the kidney? Aldosterone, right? Like via your renin-angiotensin-aldosterone system. So aldosterone is a mineralocorticoid because it's basically going to try and suck sodium back into your body, right? So mineralocorticoid, glomerulosa, so relate kidney, RAAS, ROS, aldosterone, etc. That's how I like to remember it. All right. And over here, this is labeled. So A is the glomerulosa, GFR, that's how I like to remember it. Glomerulosa fasciculata, reticularis, and then the medulla. So glomerulosa is for mineralocorticoids, F, which is fasciculata, is for the glucocorticoids, and the reticularis is for your androgens, also known as your sex steroids or your gonadocorticoids. And then your medulla is responsible for catecholamine production. So there's different types. There's epinephrine, norepinephrine, dopamine, etc. All of these things that I mentioned are in the notes under the slides, and you guys will have this shared with you right after I finish. So if there's anything that I'm saying that you want to read more about, just check the notes under the slide and it might be there. All right, next question. A patient presents with increased heart rate and heat intolerance. Which of the following labeled cells is responsible for secreting the hormone related to this issue? So pause. All right, so in this case, the answer is A. These are your follicular cells of the thyroid. And over here, you can see the colloid, which is very iodine rich. They produce a colloid and then they're secreting it in here. These are your parafollicular cells. And that's how you know. So you guys can just relate, again, like structure to function. So what is a structure and why does it function a certain way? Usually when you're studying histology, that's what you want to look at. That's why cells are shaped a certain way. So why is it shaped like this? Why is it located in this area, etc.? What is its function and how is it able to effectively carry out its function because of its structure? So over here, the follicular cells, they're secreting or creating thyroid hormone and also producing the colloid, which is basically collecting over here. So your thyroid hormone, when it's increased, you're going to have hyperthyroidism, which will cause things such as increased heart rate and heat intolerance. So I didn't mean to say thyroid stimulating hormone. Thyroid stimulating hormone is from the pituitary. So I will correct this before I give it to you guys. My mistake. I'm sorry. It's supposed to just be your thyroid hormone, so T3, and then that's converted to T4, which is active. Sorry. Yeah. All right, next question. So, which cells are responsible for secretion of the hormone that controls calcium and phosphate levels in the serum? So pause. All right. So over here, the answer would be B. And what you're looking at over here in this histology slide is actually the parathyroid gland. So over here in the parathyroid gland, you can see two main types of cells. Over here, you see your principal cells, also called your chief cells. I don't know how you guys learned it specifically. Online, they usually call it chief cells, but I remember when we learned it in second year, we would more often refer to it as the principal cells, but it's the exact same thing. And then A are your oxyphil cells. So over here, they're labeled. Now, B, which is your principal or your chief cells, are responsible for making your parathyroid hormone. And the oxyphil cells, actually, when we look it up, there's not a known function for these cells, but what people think are that they're inactive chief cells, basically, and they're very, very receptive to calcium levels in the serum. So they're probably working together in order to maintain a certain excretion of parathyroid hormone into the body, into the serum specifically, sorry. And that's basically what the functions are. So oxyphil cells are not really known, but they are very receptive to calcium, and people think that they're inactive chief cells. Chief or principal cells are responsible for your parathyroid hormone production and secretion. Now, there are also C cells, which are responsible for calcitonin. It's not shown over here. So next question. A patient undergoes a thyroidectomy. Unilateral damage to structure A would result in what? So pause. All right. So over here, when you do a thyroidectomy, and you guys have learned about this, for sure, I know they talked about it in lab for sure. There is the possibility of ligating certain arteries and nerves as well. So any vasculature and nerves. And one of the nerves that can be by mistake damaged when you're doing a thyroidectomy, aka you're removing the thyroid, is the recurrent laryngeal nerve, which can result in voice hoarseness if you cut it unilaterally. If bilaterally, it can result in difficulty breathing. So that's a very important detail to know. And it's also important to note that the recurrent laryngeal nerve on the right side will recur or loop back up at a different point as compared to the left one. The left one will go under the arch of the aorta. Okay. So quickly to review the anatomy of the thyroid. And these are your right and left lobes. It's usually located here in the lower portion of your neck. This is the isthmus, the trachea. So there are a lot of structures that can be damaged when removing a thyroid. And specifically over here, we can look at the vasculature and the nerve supply as well. So you can see all of these, usually the arteries are what you really need to know as well when they ask you about the vasculature. So make sure that you guys are well versed on that. And then this is the course of the recurrent laryngeal nerves. And your recurrent laryngeal nerves are actually from your cranial nerve 10, which is your vagus nerve. So it's also the nerve supply of the larynx. It's another way to look at it. So the sensory and motor nerves. Now, the reason that I put this here is because the recurrent laryngeal nerve supplies all the intrinsic muscles of your larynx except the cricothyroid, because the cricothyroid is supplied by external laryngeal branch of the superior laryngeal nerve, a superior laryngeal branch of the vagus. So basically just another nerve from the same main cranial nerve, okay? The reason that this is important is because you need to understand why damage of that nerve is actually resulting in voice hoarseness. It's because they're controlling your vocal cord movement, and the movement of your vocal cords, because they open like this, basically, it allows for air passage, and that vibration allows for your voice production. So if one of them is unable to move and it's only one moving, you're going to have hoarseness of your voice. And if they both stop moving, then that can result in difficulty of air entering into your trachea, which can result in obviously difficulty breathing. And this can be very, very harmful for the patients as well. All right. So over here is more about the muscles. So posterior cricoarytenoid muscle, transverse arytenoid muscle, and oblique arytenoid muscle. So everything besides the cricothyroid is controlling the movement of the vocal cords. All right, next question. What is the embryological origin of the following? You can pause. All right, so let's look at the answer. So A is from the neural crest cells, and B is from the cortical primordial cells of the coelomic mesoderm. So I'm going to go back really quickly to this over here, the first aid images right here. So over here, you can see the neural crest cells. They give rise to a lot of things. One of those things is the adrenal medulla, and then your mesoderm is actually giving rise to a lot of your glandular structures as well. And one of those is your adrenal cortex. All right. Just going to quickly go back. All right. So I think that's pretty straightforward. That's a matter of a recall. That's a recall question. That's a matter of recall. All right, next question. A woman presents unconscious and her glucose level in her serum is 25 milligrams per deciliter. And let's consider that the normal is 70 to 100. So which of the following structures is affected? I'll give you a moment to pause. All right. So over here, the answer is B. So what are these two structures? So you've already seen one of these before, and one of these is newer. So, well, you've learned it, but newer in the context of specifically this review session. So A is actually the adrenal gland. So you can see over here is the cortex. This is the outer area. You can see because there's fat and connective tissue that's a covering over the gland. And then this is the adrenal cortex, and this is the adrenal medulla. And you can see G, F, R. You can see the differences in the cells. Over here, B is actually the islets of Langerhans. So Langerhans cells. This is basically These are the beta cells. So these contain beta cells, which are responsible for insulin production. So when you do not have insulin production, or you have ineffective insulin production or glucose, what is the word? I'm sorry. Basically, when your glucose is managed inappropriately by your body, that is usually due to type 1 diabetes, which is basically where there are antibodies attacking, or not antibodies specifically, but your immune system. So cells in your immune system are reacting against the islets of Langerhans cells, so your beta cells specifically. So therefore, they cannot produce insulin, and and sometimes even the glucose management therefore is inappropriate, and therefore they can have either really, really high glucose, or it can result in them having severely low glucose. So it's just not managed appropriately. Controlled, that's the word that I wanted to use. Not managed, controlled. It is not controlled appropriately. All right, we are now in reproduction, the portion of endoreproduction that I personally prefer. And yeah, so let's get into it. So the first thing we're going to touch upon is more physiological, but you guys are probably going to get a question on this, at least one, I am pretty sure. So at which point of a female's menstrual cycle is her endometrium the thickest? So pause. All right, so the answer is D over here. So look at A, B, C, D, and E. This is the entire menstrual cycle. These are the hormone fluctuations throughout the cycle. So this is over a 28-day period estimated. And you see a rise in estrogen, and then a fall, and then a slight rise, and then a plateau of progesterone, and then progesterone increases after the 14-day mark and then starts to decrease by the end. And over here at the top, you can see the LH and FSH. Now, let's quickly summarize what this means generally. So you have an increase in estrogen, and that will decrease right after ovulation. So C is the point of ovulation. And then that's when you have an increase in progesterone. Now, the reason that you have an increase in progesterone is because progesterone is produced and secreted by the corpus luteum, which is basically the follicle that released the egg during ovulation, starts to become atretic, and it will start to secrete steroid hormones, and specifically progesterone. And the reason is because progesterone maintains the thickness of the endometrium in case there is egg fertilization. The egg will, once it's fertilized, it will implant into the thickened endometrium that is vascular. And that's basically the point of that. So that's why when progesterone is at its highest, that is when the endometrium is at its thickest. So the endometrium is thickest during point D. LH spikes up during ovulation, and FSH slightly spikes up, but not to the point of LH, also during ovulation, but is more consistently lower throughout the cycle. Now, you guys know the functions of FSH and LH, but FSH is a follicular stimulating hormone. And what you can see over here is it's slightly increased before it goes down before ovulation, but it's stimulating your follicles to form. And then at the same time, right near ovulation, your LH, or luteinizing hormone, is going to spike up. And basically, these differences, along with the estrogen spike, are going to cause ovulation to occur. So the release of the egg from the follicle into the fallopian tube, and then your LH will start to decrease immediately after, and same with your estrogen, and same with your FSH, but again, not to the same extent. Because over here now, you don't really need to be stimulating any follicles, right? But now it's going to go lower, and then through to the end, basically right after your menstrual cycle, you're restarting to create follicles again to release an egg for your next menstrual cycle, unless again it's fertilized. Okay? If you guys have any questions about that, you can feel free to ask via email. A woman who is trying to conceive is checking her cervical mucus every day to get an idea of where in her menstrual cycle she is. Her cervical mucus is watery and elastic. So where in her cycle is she most likely? So pause. All right, so the answer is C. So during ovulation, where basically there's the fertile window, aka the sperm can go and meet the egg, the easiest is during the area of ovulation, and therefore the mucus is usually a little bit more watery and elastic, and usually this allows for easy entrance of sperm into the uterus, to then go and try and fertilize an egg. All right, so usually around ovulation, it's watery and elastic. Now, if we change the question a little bit to ask, the mucus is thicker and yellow, where in her menstrual cycle is she most likely? It can either be B or A, because usually before ovulation, it is like a thicker, whiter, kind of cloudy, which is normal. And then D, usually it's going to be yellow and thicker as well. So if we change the question slightly to say her cervical mucus is slightly thick, white, and dry, where in her cycle is she most likely? Pause. She's most likely in B. So just pre-ovulation, she is in her follicular phase. Luteal phase, which is over here, the secretory phase, usually it's going to be more yellow and thick. So over here, we can see what I just spoke to you guys about, specifically in cycle, what is happening. So FSH increases, slightly decreases, and then spikes up slightly during ovulation, which is where the egg is released from the follicle. And then at the same time, progesterone is increasing because the corpus luteum is producing the progesterone in order to maintain the thickness of the endometrial lining. Menstruation is where this endometrial lining is completely shedded. And then when you enter your follicular phase again, post-menstruation, you are building back up your endometrium and it is maintained at its thickest again in the luteal phase when the progesterone is highest because of the corpus luteum, which comes from the follicle that released the egg, okay? Now, this is an ovary. So let's just say we take this image and now the question is to label an antral follicle. Pause. All right, so in this case, an antral follicle, we need to remember what an antral follicle is, so it's a secondary follicle. So over here, now this might be challenging, and that's okay. And I will tell you guys that over here, there is not only one specific correct answer. There are 3 options that you could choose or click on. So one is over here, the second is there, and the third is here. And you can see that all of these are slightly different from each other. So this is the most mature one, and this is the most immature one, but these are all secondary follicles. Now, primary follicles that come from primordial follicles, usually there is no space over there. So you're not going to see that. But as soon as you see that, then you know it's a secondary follicle, and therefore these ones are antral follicles. How do you know that they're not tertiary follicles? Honestly, if you are going to answer a question like this, it is safer to click on an option like this one or this one, as opposed to this one, even though this one would make sense, just a slightly more mature secondary follicle becoming a tertiary follicle. With tertiary follicles, there's a lot more space, they're a lot larger, and that's usually your clue. So let's say to label a Graafian follicle now. Pause. Okay, so over here, a Graafian follicle, this would be your example. So where's the egg? Now over here, the only reason there's no egg is not because that there's no egg in a Graafian follicle. Of course, there's an egg. That, the egg is in the follicle, or the oocyte, sorry, is in the follicle, and it's going to be released once the follicle ruptures, right? Due to an increase in LH and estrogen. Now, over here, the only reason that you don't see an egg is because when you're taking cross sections or cuts of this tissue, of ovarian tissue, because of the size of a Graafian or tertiary follicle, because it's larger, you might not cut through the oocyte. So if this is your follicle, which is like a 3D shape, your oocyte might be here, but you're taking the cross section or the cut from here. You're not taking it from here. That's the only reason. So that is that, just for the sake of like clearing up any confusion. But the larger follicles are going to give you more of a hint that this is most likely a tertiary follicle. So the larger, the more mature, more likely it's tertiary. But if it's something like this, where the egg is very visible and obvious and they're able to get a cut through it, it's more likely a secondary follicle. This is just a mature one. But if you're going to choose one for antral or secondary follicle, I would go with this option or this option, just because it's a little bit more clear that this is definitely a secondary follicle. So next question. Now, a sample is taken from a 34-year-old male and is being worked up for possible infertility. This is a specimen slide. Which of the following cells is responsible for steroid hormone production? So select the colored arrow. So pause. All right, so over here, the answer is green, over here. So these are pointing to the cells outside of your seminiferous tubules. So extratubular cells, these are actually, specifically these ones, are your Leydig cells. Your Leydig cells are responsible for testosterone production. And what's unique about the testicle and how it is organized histologically actually is the Leydig cells are creating testosterone, and that testosterone is localized because that high concentration of testosterone is actually what allows sperm production in your seminiferous tubules. Okay, so this testosterone is used locally and it is also going to circulate throughout your body. So which of the following cells responds to the said steroid hormone to allow sperm production? This might be slightly more challenging in terms of picking which one it is, but yeah, pause. All right, so over here, the answer is yellow. These cells right over here. These are your Sertoli cells, okay? And the reason maybe some of you might have chosen blue, and it's not blue because these are your spermatogonia. So how do you tell the difference between your Sertoli cells and your spermatogonia? One big giveaway as you look at the nuclei and the color specifically. So your Sertoli cells are slightly larger and they're a lot lighter in color, specifically in the nuclei, whereas your spermatogonia, your nuclei, they look more condensed, so they look a lot darker. That's going to be your main clue. Another one is a location. So Sertoli cells, yes, they're peripheral, but they do spread in a little bit because they're bound to the spermatogonia and the forming spermatids throughout, right? Until the spermatids are released into the lumens of your seminiferous tubules to go to the epididymis. Over here, your spermatogonia, which are your most immature primary form of what are going to become your sperm, they're going to actually be outside the Sertoli cells and not near to the tubule. And again, you know from the color, and now you also know from the location. And the reason is because these are still diploid cells, and they have the exact same genetic makeup of the rest of the cells in your body. So you don't want them to be inside because, again, the Sertoli cells make up your blood testes barrier, okay? And your blood testes barrier is there because you don't want the haploid cells or the cells with antigenic differences to be exposed to your immune system because they are recognized as foreign, so they might be attacked. So the Sertoli cells basically work in that. So the spermatogonia are here, and then the Sertoli cells are right here. Around the same area, they're both external, kind of in the outer area of your seminiferous tubules, but that's how you tell the difference. So now, this is a more, I guess, interesting question, but match the following cells to their function. So pause and feel free to take your time, and then we'll continue. All right, so let's go one by one. So green over here, as we just mentioned, Leydig cells produce testosterone. So this is going to be with this testosterone production. Now next, let's look at the blue. So the blue over here are, as we mentioned, the spermatogonia. So what are they going to do? They're going to undergo mitosis. They're going to divide. So there's two types of spermatogonia that you guys learned about, type A and B. We're not going to talk about how to differentiate type A and B histologically, but just for the sake of function, know that type A basically divide, keep on dividing basically to make more type B. And type B are the ones that are actually going to undergo the maturation to become sperm. All right, next is yellow. So we talked about this. We know that these are Sertoli cells. So what are Sertoli cells responsible for? Sperm production and also contributing to creating the very, very important blood testis barrier, okay? Next, pink. So let's look at these. So what are these? I sometimes forget the names, but over here they're at the bottom. Okay. All right. So the pink ones over here are your primary spermatocytes, okay? Let's just put these back. So primary spermatocytes will usually undergo meiosis. And the reason for this is because now they're going from diploid to haploid, and then they will then divide in that way then. Now they are haploid cells, okay? Now next is orange. What are these? So orange are your spermatozoa, and your spermatozoa are going to undergo spermiogenesis. So spermiogenesis is where it's undergoing slight maturation in order to, become a proper sperm that can travel through to the epididymis and then through ejaculation into the female reproductive tract in order to go and fertilize an oocyte, right? Now, these are still immature. They're not fully mature yet. But these are your spermatids. Now, next red, then the smallest ones, and you can see they're very tiny nuclei. These are your spermatozoa. Okay, so now your spermatozoa are going to be released from your Sertoli cells because up until now, through special junctions, all of these developing sperm are still attached to your Sertoli cells. So now these are going to be released by your Sertoli cells into the lumen of the seminiferous tubules, and they're going to travel to the epididymis where they will complete their maturation and gain motility. Okay. All the notes for this are in the notes section under the slide. So next, over here, we can just see this a little bit more close up. So like we said, these are the Leydig cells. These are extratubular. These are your spermatogonia. These are your Sertoli cells. These are your primary spermatocytes, your spermatids, and your spermatozoa, okay? Now, next question, more gross anatomy instead of histology. So which pelvis belongs to a male, A or B? Pause. Okay, so the answer is B. Now, what are two characteristics that tell you so? So how do you know that this is the pelvis of a male and this is one of a female? What's the difference? Or what are the two differences? Pause. All right, so the two differences that you guys can see are one, the sacral promontory, which is more prominent, and a narrower pubic arch. So this is your pubic arch over here. It's more narrow, and then the sacral promontory is this area right here. So if you compare it to that of a female's, the sacral promontory is actually not as prominent as a male's is. The male's sacral promontory, if this is like a female's, this is a male. It's just pointing out a little bit more. All right, pretty straightforward. Next question. So a baby presents with this finding. What is it? So first of all, what is the finding? So pause. All right, so in this case, a baby, when they look through the scrotal sac, they see that there's translucency when they shine light. And usually this is a sign that there is excessive or there is the presence of fluid in the scrotal sac. That is not normal. There is not supposed to be any presence of fluid in the scrotal sac. So over here, what is this? This is known as a hydrocele, okay? So the next question then that they can ask you is between which two layers shown in this cross section over here of the scrotum and the testicle is the collection of fluid collecting in? So pause. All right. So over here, the fluid that collects in a hydrocele is actually collecting in between F and G. So what are F and G? What are these layers called? These layers are basically the tunica vaginalis, but specifically F is the parietal layer of the tunica vaginalis, and G is the visceral layer of the tunica vaginalis. Under that, you have the tunica albuginea, which is directly covering the testicular tissue, the seminiferous tubules and the septa. Okay. So over here, this is an image from Amboss directly. You see the parietal layer, the visceral layer folds over like that. And typically when in utero, when the baby is growing and developing, this area is still open and accessible to the abdomen, but then the processus vaginalis closes off. Normally it'll close off and then it'll be normal like this, unless it closes off abnormally and then there's still a collection of fluid. This is not harmful to the patient, but it is something that is abnormal. It's not supposed to be there. So you can usually remove this via a hydrocelectomy. So this is a fluid collection in the cavity of the tunica vaginalis in between the parietal and visceral layer. Okay, don't make the mistake of saying that it is a fluid collection in between the tunica vaginalis and the tunica albuginea. That is incorrect. It is a fluid collection in between the two layers of the tunica vaginalis. That is a mistake I've made in the past, so I just want to clarify for anyone who might make a similar mistake. All right, next question. Which two arteries differing in males and females branch off from the labeled artery? So pause. All right, so in this image over here, the arrow is pointing at a specific artery. So what is this artery? So we know that it is the internal iliac artery. And this will give off the two branches that are different in males and females, which are the inferior vesicular artery in males and the vaginal artery in females. Okay, so there are many branches of the internal iliac artery that you guys need to know. And I put them right over here. So I'm sure you guys have seen this exact image before as well. You have your, sorry, your internal iliac is going to give off a bunch of branches, and you guys do need to know these branches. And sometimes they might not ask you the question I just asked you, even though I think that has come in the past. But what they might ask you instead is to name 3 or 4 branches. They might ask you to name 5 branches. They might ask you to name all branches. I doubt they would ask you to name all, but you definitely do need to know all. Okay, so they start from here. So lateral sacral artery, superior gluteal artery, inferior gluteal artery, internal pudendal artery, middle rectal artery, uterine artery in females, or artery to the ductus deferens in males, also known as the differential artery. Then you have the vaginal artery in females, or the inferior vesicular artery in males. And then you have your obturator artery, and then your superior vesicular artery, or superior vesical artery. Now, for example, for the testicular blood supply, your testicles are supplied by 3 arteries at anastomose: your testicular artery, cremasteric artery, and your artery to the ductus deferens. Okay, so now you know that the artery to the ductus deferens actually branches off of the internal iliac artery, specifically from the, if I'm not wrong, inferior epigastric artery. No, sorry, my mistake. The cremasteric artery comes from that artery from the external iliac artery. Okay, sorry, this one, my bad. We just did it. The artery to the ductus deferens is coming from the internal iliac artery, and the testicular artery branches directly off of the aorta. Now, when it comes to venous supply, your pampiniform plexus, which will lead into your testicular veins, are going to drain slightly differently. So your left testicular vein is going to drain into your left renal vein and then into your aorta, whereas the right testicular vein is going to drain directly into your aorta. Okay, so make sure you guys do know that. All right, next question. So what is the structure pointed to by the blue arrow called? Over here. So pause. So this is known as the perineal body. And the perineal body basically is where a lot of the pelvic floor muscles will attach, and it can get damaged in childbirth in women. So what they do is an episiotomy. So if this is the vaginal opening and your perineal body is here, for example, they will cut diagonally over here and make an incision so that there is more opening in their space for the baby to be delivered. And so it won't normally, unless you do this, then it would possibly tear the perineal body. So now it's not going to tear the perineal body because you've already made a slit and opened up the space for delivery. So now next question. What is the main arterial branch that supplies the start structure? So the main arterial branch that supplies the start structure over here branches from which artery? So what is the main arterial branch that supplies this? What is this, first of all? So pause. All right. So the uterine artery, because this is the uterus, this is the bladder, pubic symphysis, bladder, uterus, and then this is the rectum. So the uterus is supplied by the uterine artery primarily, and then the ovarian artery. So the uterine artery comes from the internal iliac artery, which we just spoke about over here. Okay, so the uterine artery is coming from the internal iliac artery. Now the ovarian artery anastomoses with the uterine arteries, but the ovarian arteries are branching off directly from the aorta. Okay, which is written right over here. So over here, we can see this more clearly. This is your internal iliac artery, gives off your uterine artery, which is the main arterial supply for your uterus. It anastomoses with the ovarian artery, which is coming from your aorta directly. And then your internal iliac artery, like we discussed just a minute ago, also gives off your vaginal arteries in a female. In the male, this is the inferior vesicular or inferior vesical artery. Now, Next question. What happens to spermatozoa in the structure? So pause. All right. So when you look at the structure, when you look at this histological slide, you should know that this is the epididymis. And as I mentioned a little bit earlier, the epididymis is where the spermatozoa go to complete maturation and gain motility. Okay. This is incredibly important because this is absolutely necessary in order for sperm to be able to successfully travel in a female reproductive tract and fertilize an oocyte. Okay. And that is it. That is it for the review. If you guys have any questions, please feel free to contact me literally anytime. I will answer you as soon as possible. I know your final is very, very soon, but feel free to, if you want the quickest response, WhatsApp is the best. If you want to do email, feel free. Otherwise, you can DM me in any way that you have contact with me. But one thing that I just wanted to tell you guys is usually the questions will come in these types of formats, but they might apply it to different concepts or different, for example, things that you learn about in endocrinology reproduction. So just make sure that you're looking at these questions and seeing, okay, what could they possibly ask me about this specific structure? What could they possibly ask me about this specific structure? I feel, in my opinion, that is the best way to prepare for an OSPE. And just ask around and look over what they possibly might have asked in the previous batches, because that will give you the best idea of how they might ask you questions. They might not be exactly the same, in all honesty, but they usually are in the same route. They'll usually ask you similarly formatted questions, but about different things. Or instead of focusing on this structure now, they might focus on this structure. So they might ask you the function of this. So just make sure that you guys keep that in mind. All right. And again, if you guys have any questions at any time, please feel free to ask. I'm more than happy to answer and help you guys out. Best of luck. Allah yuwaffiqkum. You guys are going to do amazing. All right. Thank you guys so much. See you soon.